Welcome to the Physio Matters podcast, this month in association with Rehab My Patient, and this is session 91. Hello and welcome to session 91 of the Physio Matters podcast. This month you've got me, Felicity Thow, talking to Dr Katy Munro, who I'll introduce in just a second. We're covering a session on headaches and migraines, so not something that patients would necessarily see us for in isolation, but certainly something that they live with alongside other pain problems. But first, a bit of a roundup on the past month. You will have most certainly seen that Therapy Live has been and gone. Therapy Live 2021. You may have heard there were some technical issues that were just outside of our control, but we really hope we've made it up to everyone. If you did have a ticket to Therapy Live, please check your emails. We have news for you and treats for you to make up for any issues that you might have had on the day. If you have already paid for access, if you are an MSK founding member, if you're a Physio Matters community member, do head to physio-matters.com to watch all the recordings at your leisure. There's every single session from every Therapy Live we've ever done. It's brilliant. And if you want to purchase the recordings and you've not done so yet, you still can. So on to today's session, and I'm delighted to be joined by Dr Katy Munro, who is a GP and headache specialist at the National Migraine Centre. She's also no stranger to podcasts as the host of the Heads Up podcast to do with migraines, and that's a patient-facing pod. So Katy, thanks very much for joining me. Would you like to introduce yourself a bit further?
Yes, indeed, and thank you for the invitation. So I started off my career as a GP, and then during the course of my work discovered that I was getting migraine, and that led to me being very interested in how to get the best help and how to really sort my own migraine out. And as part of that journey, I found the National Migraine Centre, who are really very, very helpful, and finally changed my career path a little bit and started to work as a headache specialist with them. So the National Migraine Centre is a charity that people refer themselves to for headache care. We're really, really busy at the moment, and I think the combination of the lockdown and sort of long waiting lists in the NHS has made things busy. But yeah, one of the things that we realised that we were constantly saying similar things to people about general advice, and that's why we thought that our podcast Heads Up would be a useful thing, and that's been really fun to do as well. So yeah, I have a number of colleagues who also work as GPs, and we have some consultant neurologists, and our mission is not only to help people learn how to manage their own headaches, but also to educate other people who don't get migraine, and to help them understand it a bit more, because I think it's a lot of misunderstandings and myths about migraine out there.
Absolutely, and I think for the reasons for getting you on the podcast were kind of twofold, and that's one of them. Pain is complex, and I wondered if learning about the complex presentations like migraine might help us put together the pieces in persistent, widespread pain. And secondly, I think as physios, we go, okay, you've got pain, cool, yeah, I can manage that. Yeah, it's widespread, it's all over your body, great. Oh, you've got pain in your head. And then we kind of understandably kind of run out of steam and think, what? So I wondered, what kind of advice we can give to patients and what kind of knowledge, but we'll come to that. So that's brilliant. Yeah. And as you say, it was migraines themselves that led you to migraines. It was living with them yourselves.
Yes, it was actually, and it took me a while to twig because I didn't know that much about migraine. And think, being a GP by career, you have to learn a bit about everything, but you don't have that much time in consultations. You only have 10 minutes, and you need to almost be a mini expert in so many different conditions. But actually, with caring for people with migraine and other headaches like cluster headache and some of the rarer headaches that we see, I think it's not that complicated, but it does take time, and that's one of the joys that we have. Much more time. We have 45 minutes or maybe an hour to really listen to the patient's story and work out what's going on. GPs are very willing to do that, but they often just are so pushed for time.
Yeah, absolutely. And do you mind me asking, do you still live with migraines now?
Yeah, I still get them from time to time. I know why I get them a bit better. And I know I've sorted out a good acute treatment, a rescue treatment, as we call it. So if I do get one, I can get rid of them quite quickly. Unfortunately, at the moment, they're not coming thick and fast, so I'm not on a preventative. But I have had that in the past. I think it changes. I think migraine changes throughout people's lives. And this is something that we quite often hear, is that they might say, well, when I was younger, I used to get this, but now I've got older, it's changed a bit. And that some people don't get, I didn't start getting them till I was in my 40s. But some people, I mean, my youngest patient that I've heard having migraines with Aura was a 3-year-old. And his mum spotted it because she had migraine as well, because we know it is a genetic neurological condition. And so I'm always saying to people, it's a genetic neurological condition. It's not your fault. And it's a lifelong thing, having those genes. We can't take the genes away, but it's the impact of the environmental changes that make the person with a vulnerability to migraine actually have attacks. And so that can be changes in their internal environment or changes in their external environment. And those kind of combine in random different groups to push the brain into a threshold across which once you've crossed that threshold, then you're much more likely to get a migraine attack. And the more often that happens, the more likely you are to turn from episodic into chronic migraine. So it's really a passion of mine to try and get really good advice in early so that people can manage their migraine better, and then they diminish their risk of getting chronic migraine.
Brilliant. I mean, it just sounds like the ultimate representation of the biopsychosocial model, doesn't it? It's just like all of everything can be affected.
Absolutely. I think so many factors. So sometimes people come to clinic and say, oh, I don't know what it was that caused it. I've tried to find the trigger. And of course, the answer is it's a combination of triggers. But it can be useful to think about what was happening the day or two before your migraine attack started, because that can give you a little bit of clue to what things going forward you might be able to manage. And those are quite basic things. So that might be having a regular meal times, having a low carbohydrate diet, having regular sleep. That kind of thing can really, really help. And I think more than people realize. The other thing about the genes is that because the migraine runs in families, it often gives us a clue. If people say, oh yes, and my mum had it, or my grandmother, or my aunt, or whatever, it's often more common in women. So about 3 times as many women get it as men. And it's more common than people realize. It's about 1 in 7 people get migraine attacks. Yeah. And that, that's extraordinarily common, really. But often people don't realize that that's what they're having.
Right.
So we ask some basic questions. So we will say to people, do you get sensitivity, heightened sensitivity to sound, light, movement, smells, and even sometimes touch? And if they have some of those, that's a clue. And then we also ask them if they get nausea or vomiting, because we know that migraine attacks cause gastric stasis because they work on the vagus nerve. But I think the overlap with people with persistent pain is this kind of heightened irritability of the brain, where it's misinterpreting things too quickly and sending out pain signals. So we do see a lot of people in clinic who have migraine attacks, quite obviously, but they may also say, well, I have fibromyalgia, or I have hypermobility issues, and I have Ehlers-Danlos or POTS. And there's a lot of overlap with other conditions. And of course, the other thing they commonly have is anxiety or depression. And I say to people, the brain is all joined up. There isn't a section that the bit of your brain that sorts out anxiety isn't working, and the bit of your brain that feels pain. It's all really connected, isn't it?
Yeah.
So it's anything that you can do to help improve the resilience of the brain, if you like, and push that threshold for the brain feeling pain further away can be really helpful.
And I think we see that in the populations that we see, that it is often the people with, as you mentioned, fibromyalgia, Ehlers-Danlos, that's where the prevalence of migraines and headaches are. And when we're often, I think very rarely would a person come to see a physiotherapist just with a migraine, because they're often coming with other things. They're coming with widespread pain. And we know that the risk of having persistent pain increases with the more body sites there are. Do you find that with headaches and migraines as well? The more widespread your bodily pain is, the more likely it is that the head is going to get involved?
I think, yes, that probably is true. I think a very common one that we see is people saying, oh, and I also get really bad neck pain. And sometimes they've had specific pains that they've gone down a route of trying to find out what that pain is, not realizing that actually it was linked to their migraine. So we have children who have seen a lot of pediatricians or GPs with recurrent abdominal pain, and actually that's a symptom of migraine in children. Sometimes people are not aware that children can have migraine attacks that are mainly abdominal pain. They not get headache at all. And then we'll see some adults who've been off to see ears and throat surgeons because they think they're having recurrent sinus infections. But actually, again, that's often a sign of a migraine attack. Personally, I get a pain sometimes in my sinus, feels like a knitting needle pressing through. And again, it took me a while to realize that was just a slightly different expression of my migraine attacks.
Right.
And neck and shoulder pain is a really interesting one. I'm sure that you, as physios, will see people who have recurrent neck and shoulder pain, and they say, well, sometimes it's really fine, but other times it's really bad. And that can be because the migraine and the neck have what we call a bi-directional relationship. So if you have tension and problems in your neck and shoulders, that can send signals through the cervical nerves up into the part of the brain generating migraine and trigger an attack. And if you have migraine, you're much more likely to get referred pain from the actual attack down into your neck and shoulders. And sometimes that can be quite difficult to tease out, because people say, well, I had a whiplash, or I've had a muscle strain, but actually some of that is generated by their migraine aggravating it.
Yeah. That's fascinating. You can get abdominal migraines. And especially in a child, how do you kind of tease that out? That's must be difficult.
I think the answer is thinking of it first of all. So what we would say is, if you have a family history of migraine, so mum or sisters or grandparents have known that they've had migraine, and the child is getting bouts of abdominal pain, often it's linked with travel sickness, so that is very much a linked condition with migraine. Then if the child is getting bouts of tummy pain where they look pale, they might feel sick, they might need to go off and lie quietly in a dark room because the light's too bright, or the noise of the telly, or their siblings jumping about is just irritating them and aggravating the pain. That is a classic presentation of migraine in a child. Sometimes they'll get headaches as well. And sometimes as they get older, the headaches become more pronounced and the tummy aches fade away. But if doctors don't think of it, or parents don't kind of think, oh, could this be migraine, then they can get put through all sorts of tests. And because it's tummy, you can imagine the kind of tests. They can have tubes put down from the top or up from the other end, which is really uncomfortable and not very pleasant for a child, when actually what they need is a good migraine treatment. Well, it's quite simple in children. Sometimes it's just simply about getting the dietary regulation right. So I had a boy who was about 12 and he was getting 15 migraines a month. And his mum simply put in a bedtime snack, and suddenly his brain quietened down. And over the course of the next couple of months, he much reduced his frequency of attacks down to about 1 a month. And that's because we know it's fluctuations in blood sugar that is a big trigger for the brain to have an attack. And of course, we often give kids their tea, sort of 5:30 or 6ish, and then nothing to eat till the next morning. Sometimes kids are skipping breakfast. The other thing with children is the changes that we hear in so the changes that they're going through in puberty, so growth spurts. With girls, of course, it's the onset of menstruation and the menstrual cycle kicks in. With going to secondary school, it's a change in stress, possibly, or excitement. It may be that they're also needing a little bit more sleep than they can get, because we know that the teenage brain needs an extended period of sleep. And probably teenagers would be better to go off to school at about 10 o'clock in the morning rather than having to leap out of bed at 7. Not many teenagers do the leaping. They will do the
dragging,
the wriggling and rolling and reluctant dragging out of bed. So trying to get all those things right. So routine is a key word for kids, routine. And exercise, of course. Exercise really important for anybody with migraine. But it can depend on the type of exercise, because sometimes that can be a trigger if people haven't had enough to eat or if they're a bit dehydrated. And going back to the neck and shoulders, if people are doing sort of weights or doing exercise like breaststroke or maybe cycling where their neck and shoulders are a bit hyperextended, then sometimes they'll come and say to us, well, I can't do that kind of exercise because I'm definitely going to get a migraine afterwards. So there's loads of general advice that can really help people manage their own attacks and try and reduce the frequency.
Definitely. I'll come back to that about diet and exercise and the things that we can potentially be in our remit of advising people on. I wanted to touch on, because we talked about, as we say, what a migraine entails and the features of that. You mentioned some of the things to look out for, the nausea, the kind of sensory disturbances. Is it one of those being present with head pain that makes it a migraine, or is it more 2 or 3, or a combination of?
It's really just building up the picture of a combination of the set of symptoms. So it may not be every single time. It may be that you need to have had more than just one attack. So we wouldn't normally diagnose migraine unless somebody's had at least 3 attacks and they have a couple of those other features. And it's really about the impact on their lives as well, and whether they've had to stop doing the things that they'd normally like to do. That helps us build up the picture for the diagnosis. I find I went to a lecture years ago now, and one of the consultants said, if somebody says their headache gets worse when they move and it bangs when they move, that's almost diagnostic of migraine. So we often find people are diagnosed with tension headache, and that's greatly overdiagnosed, because tension headache is a featureless headache. So they have like a dull pressure around the skull, which doesn't change with movement. They don't get irritated by light or sound. They don't get nausea and vomiting. So that tension headache is really a featureless headache, where migraine has these very obvious sensitivities because of it seems to be the processing of the brain to sensory inputs, which is the underlying problem caused by that genetic vulnerability.
Cool, yeah, and as you say, genetics is certainly one of the causes of this, and we talked about stressors and things like that as well contributing. Are there any other risk factors that we can screen for, be aware of, that might contribute to migraines?
Well, some people would say that the risk factors would be things that they are eating, and people are often rushing around trying to exclude, I'm looking at this and I've stopped eating that, and I've read this book that tells me not to touch any of these gazillion foods. That's much rarer than people think. What we used to think was that certain foods were definitely triggers, but then some studies were done which found that actually craving certain foods can be part of the prodromal phase. So the prodromal phase, one of the 4 phases that we describe in a migraine attack, can last up to about 48 hours before the headache phase or the aura phase, which some people get, about a third of people get aura. So in that prodromal phase, some people really crave carbohydrates and they might go and have a bit of chocolate. And then the headache comes and they say, oh, chocolate is causing my migraine attack.
Right. Yeah.
But actually it seems that it's more of a symptom, a warning sign. So why is it to be, well, if you get that craving, get in there quickly with your rescue treatment, because it means that a migraine attack is on the way. There are some people, I think, who genuinely have got food triggers, and that's becoming a little bit more something that we're aware of. But I think more, like everything with migraine, more research needs to be done on the relevance of these. So I certainly have some patients who've looked at food intolerances and found that specific things like maybe caffeine or maybe dairy, or maybe some people are sensitive to histamine containing foods, and by cutting those out, that has really helped. But it's quite tricky to cut out every single thing that you will have read that people may or may not have, and I don't usually advise people to do that. If they've got a food trigger that's a genuine food trigger, they will normally know about it quite easily. So I have a friend who, every time she eats a citrus fruit like a satsuma, she will get an aura fairly soon afterwards. So she knows that is something for her to avoid. But most people, you can hear all the different people say this, all the C's of citrus, chocolate. I can't remember what they all are because I never say them to patients. But I think people can get too fixated on that, and thinking about routine generally and eating things which are more low carb is probably a more helpful thing. Other risk factors, times of hormonal change in women, big time of risk. So we've talked a little bit about puberty, when estrogen levels are going up and down, and then the cycle kicks in. Then pregnancy. So pregnancy is a time where sometimes estrogen levels stabilize nicely and people stop getting migraine attacks, but sometimes the heightened level of estrogen can start people having migraine when they haven't had it before. And that's because people who have migraine with aura, it seems to be high levels of estrogen that push them into having attacks, whereas people who have migraine without or without aura, it's the dropping levels of estrogen. So they tend to get more migraine attacks when they're about to have their period, or if they're on the contraceptive pill, when they have that pill-free week, they'll suddenly start getting an attack. And then around the perimenopause and menopause, of course, estrogen levels are a big factor then. We see a lot of women finding that their migraine are much worse around the perimenopause, and that's because estrogen levels decline, but not in a linear, smooth fashion. They go down a bit, up a bit, like a roller coaster. And on the times when they're going down, then people are more at risk of having a migraine attack. So yes, those are the kind of contributory factors, really.
Yeah. Oh gosh, the menopause has a lot to answer for, doesn't it? We have a podcast coming up in the coming months about that, and it's
excellent. Yes, I think, smoothing out estrogen is basically the answer to all of the things I've mentioned about hormones. The more we can smooth out estrogen so that it's not fluctuating, then the more likely we are. So I'm a huge fan of talking about HRT with perimenopausal and menopausal women. I think there's a lot of really good information out there now, and we certainly, we see it. So many people who have been frightened of having HRT because again, I talked about myths, there's a myth that you can't have it. If you've got migraine, you can't have HRT. That's absolutely wrong. You can, assuming there are no other reasons, obviously. But I think there are some myths that people have mistakenly been told sometimes about hormones.
Yeah, quite widely by media outlets. Absolutely.
Definitely.
I want to clarify about the aura, because that's something that it fascinates me. It's that's the kind of visual disturbance, isn't it? The aura.
It can be visual. Most people, it's visual, but it can be other senses. And so sometimes people can get aura where they hear things. Sometimes they can get aura where they smell things, strange smells, burning cigarettes, that kind of weird thing. And sometimes they get aura where they get weakness down one side. They might have facial weakness or feel that their one side of their arm or leg is not working properly. But the visual aura is much the most common. So the definition of aura is a change, with a neurological change, like a visual disturbance, which comes and goes within an hour before the headache phase starts. And so people sometimes come and classically describe it to us, and I'm sort of, I wish there was a medical student here I could tell this to, because they'll say, it starts in the center and I see a little disturbance in my vision, and then sometimes it's a zigzag or flashing lights, and it spreads outwards from the center, and they start to draw a zigzag in the air as it goes out. And sometimes they have a blind spot as well, and then it may be black or white, it may be colored. Sparkly is sometimes how people describe it, and then it fades off. When you first have it, it can be a bit alarming. But once people know what it is, it's that very early warning sign that headache's on the way. That again is a time to really get in there quickly with your acute rescue treatment. I had a man who came in to see me a few years ago, and he said, I don't get headache, I just get aura. I quite like it, actually. He said it's a bit like a kaleidoscope. It's really pretty, and it never gives me any bother. So you can get migraine aura without headache. Which again is confusing for some people, but most people will get aura that comes and goes within an hour, and then the headache and it's not just a headache in the headache phase, it's all the other things like nausea and vomiting and brain fog and word finding difficulties. Sometimes people feel exhausted, their fatigue kicks in, they can't think straight. I used to find that it was like hard work to think, and almost even hard work to see. So I could see, but it was almost like I had to work at seeing. It's a very strange set of brain disturbances when you're in the middle of an attack. And I think one of the mantras in the migraine community is it's not just a headache, because there's so much more.
Absolutely, I can vouch for that. I've had auras myself without pain. It is a strange thing, but it is quite a terrifying thing the first time you have it, especially, as you say, some people are presenting with auras that are hemiplegia. I imagine that people end up in A&E with these kind of symptoms. Is the key that they ease up in the very short term? That's always reassuring. Depends also on whether that's the first occasion. So if it's the first occasion, especially if somebody was older and they'd never had it before, I would encourage them to get checked out by their doctor, because there is an overlap. Sometimes people get these kind of symptoms with transient ischemic attacks or, with the onset of a stroke. So I think with any new symptoms, we'd always say, go and see a doctor. Don't just kind of go, it's probably migraine, and put up with it if you haven't had that before. But if you know that your migraine attacks always give you this kind of heavy feeling down the side of your body, or you can't find your words or whatever, people get used to that and they know what it is, and then they don't need to be rushing off to the doctor with that. I had a patient who was working in the NHS actually, and she was an occupational therapist, and she had that sort of hemiplegic migraine quite profoundly, so she couldn't move her arm or leg.
in the aura phase, but her physio colleagues did acupuncture. And they would just pop a little acupuncture needle into between her thumb and forefinger, and that would sort her out. Well, she swore by that, which was very interesting. But a lot of people with hemiplegic migraine actually don't have true hemiplegic migraine. They have more of a feeling of heaviness. And when you specifically ask them, can you actually move? They say, well, yeah, I can move. It just feels weird. And that's not true hemiplegic migraine. Hemiplegic migraine has specific genes. There's a different set of genes have been identified, and again, one of the youngest I've seen having hemiplegic migraine she was about 7, and she had really quite profound attacks of hemiplegia, which went on for a prolonged number of days. So that's quite a rare variant. But this feeling of heaviness is quite common. Dizziness is another symptom. People often say, oh, I feel really lightheaded or dizzy, and that seems to be more pronounced as people get older. So people, women going into the perimenopause will often say, well, I used to get symptoms of pain and maybe vomiting or whatever, but now I just get really dizzy. I don't know whether that might be something that would come to your clinics, whether people would come complaining of dizziness as well. Certainly vestibular. And vestibular physiotherapy can be really helpful for those kind of people who are getting dizziness symptoms.
Is it a certain kind of dizziness that they report? I know dizziness means a lot of things to different people, doesn't it? There's that kind of postural hypertension dizziness, the spots in front of your eyes, and then there's room spinning. Is there a certain kind of dizziness that people report with migraines?
I think it can be all of those, actually. So it can be that they're feeling unsteady. It can be that they're feeling that the world is spinning. It can be motion sensitive dizziness, so they see something moving. I don't generally get dizziness, but if I'm standing in a tube station and the train whizzes past me, that kind of visual movement makes me feel I have to look away. I can't look at those. And I think sometimes, if people are playing those high movement games on computers or looking at things that are whizzing past, so it might be escalators or something like that, those can make people feel quite dizzy. So it's visual sensitivity in that way. So I think dizziness is a very common thing that we hear about.
Yeah. And is that just in the duration of a migraine attack, or is that all of the time that you'd feel like that?
Usually, if it's episodic migraine, just feel like it during the migraine attack. There is a particular type of dizziness called vestibular migraine, and sometimes people just have dizziness and don't get the headache. And the dizziness in those attacks persists from anything from a few minutes to 72 hours, and in some cases even lasting for a number of weeks. And then again, we were talking about people presenting to different specialties. If they've ended up in an ear, nose and throat clinic with dizziness, it's very useful if that person who they're seeing thinks, could this be vestibular migraine? It's really quite common, actually. And so if there's any hint that sometimes I was speaking to a mum the other day, said to her, your daughter's clearly got migraine. Do you have migraine? And she said, oh, no, I just get these horrible dizziness attacks with headaches around my period. And I was like, oh, okay. That's called vestibular migraine. People, as I said, people often don't realize that that's what they've got, and it really helps. This is why one of the things we try and do in the podcast is make it useful for people who may have symptoms, but also useful for GPs. And we've had a lot of GPs saying, oh my goodness, I've learned so much from listening to your episode on whatever it is.
Brilliant. I wanted to talk about a thing that we hear a lot as physios when we're working in pain, and we always say, there's so many factors that can affect, say, your low back pain, multiple factors. And we, of course, when you have low back pain yourself, you do assume, oh, is it the worst thing possible? You know, have I broken something? Has my disc exploded? And when we start to bring in the idea that perhaps there's more environmental things, social things, psychological features that might have a bearing on that, stress levels, etc., how much sleep you had last night, it can be hard for people to accept that. And I've heard a lot fairly recently that what about if we compare it to headaches, where people are a bit more accepting that, oh, I am just really stressed, I've got this work deadline, my head's killing me. But is that true? Do you think people are a bit more readily accepting of that as a cause, the whole psychosocial spectrum of causes for pain in headaches?
I think we have to be careful, because unfortunately, some people have been told, oh, it's just stress. And I don't think it is just stress, but I do think the stress is a major contributory factor. So it depends really how accepting they are as to whether it's been explained to them in the ways that you describe as the whole biopsychosocial model. And that's one of the things we try and take a lot of time to do, because we know, as I said before, that it's change. So anything which changes in your neurochemical makeup can contribute to the brain irritability. So of course, if you're getting stressed about something, you have more of the stress hormones, higher level of those can aggravate. But also, interestingly, if people are suddenly winding down from a period of stress, then that is a change. So that can aggravate a migraine as well. And then excitement is the same. So people getting very excited, and we often see this in children. Oh, I've got a birthday party coming up, I'm really excited. Oh, now I've got a migraine attack on the day of the birthday party. But travel is a big thing. So anything that's disrupting your normal routine. And with travel, I always say, travel in the days when we were able to travel, you would often be stressed because you had things to sort out before you could go. You would possibly be excited if you were going on a nice holiday. You would have disrupted sleep because we've booked, a very nice cheap flight that has to be at the airport at 2 o'clock in the morning. That disrupts our sleep cycle, our eating cycle. Airports are full of glare, noise. How does anybody go away on a flight and not get a migraine attack? Is a mystery to me. But I think people know, once we explain about the combination of things adding together, that's the light bulb moment, because people then go, oh, right, I know now that I have to work on a range of things. I think when they first come, sometimes they are thinking there's a thing. And if there's one thing they can discover, that'll fix it. And it's never that easy, sadly. They sometimes, going back to your thing of people sort of fearing that their back is broken or that their discs exploded, I think obviously when somebody first starts getting migraine attacks, they may be worried that they've got a brain tumor. And they may see their GP for reassurance about that. Especially if they've had migraine attacks and things change a bit, or if they're having them more and more and more and more frequently, they think, well, maybe there is something horrible underneath. The thing about brain tumors is that usually they are accompanied by neurological signs. And so if somebody does a neurological examination on a person who's getting frequent migraine attacks, and that's completely normal, that's very, very reassuring. Also, with episodic migraine, the person will be absolutely fine in between attacks. When it comes to chronic migraine, which is more than 15 attacks a month, then they may have very few what we call crystal clear head days. They may just have residual symptoms for quite a lot of the time, albeit maybe low level. And that's when they begin to worry. And I think it's worth just talking about those worries with your GP. Sometimes people think they should have a scan. And scans, the trouble with scans is that sometimes they can show up things that are actually nothing to do with the migraine attacks at all. But they do raise people's worry and anxiety levels. And there was a study a while ago that looked at people who'd had scans, who were getting frequent migraine, and how long that reassured them for. and a normal scan reassured people for only about a year. So
Right.
it's really not something that we are pushing people to get.
Yeah.
But obviously, again, if there were new symptoms, or if you were starting to get headaches or migraine attacks after the age of 50, or if you had something that, we might worry about, secondaries from a previous cancer or lower immune system or something like that. So breast cancer or prostate cancer diagnosis, and then somebody starts getting new headaches, I would always get that checked out. So the things that we call red flags, really, which your doctors should be able to advise whether a scan is necessary. But it really isn't necessary if there's just a very classical history of migraine attacks.
Got you. And as I say, is that any length of time after a prostate or breast cancer diagnosis you start getting
Yeah.
Yeah.
Yes, I think so. If it's new, then get it checked out. Yeah.
Fair enough.
The other one should just say, while we're talking about red flags, is thunderclap headaches. So thunderclap headaches are quite different from a migraine attack. They come on like a baseball bat hitting you on the back of the head, really like an explosively sudden, severe, horrible pain. And people who get this, describe it as being like an explosion in their head. People need to go to casualty straight away, get this checked out. So sometimes they happen out of the blue, sometimes they happen during sexual intercourse, and if it's the first time it's happened, go to casualty, because it can be a warning sign of a bleed in the brain. It isn't always, so don't panic. It may not be, but it can be, and if that isn't sorted, then the consequences can be dangerous. So I'm always saying to people, we shouldn't be seeing people with thunderclap headache in our clinic, because we're not a casualty. We see people, after a bit of a wait for an appointment. So a thunderclap headache is a medical emergency. Off you go to casualty and get checked out. Might need a scan, might need a lumbar puncture, but definitely needs investigating.
Fair enough. I think there'll be a lot of physios who've ever done rotations or work on neurosurgery nodding along going, yeah, that's exactly what people describe, isn't it? Like a shovel hit on the back of the head, or just a very sudden blow to the back of the head without any actual force. And could that I'm thinking, people could get that, and you assume, oh gosh, if you're having a bleed in the brain, that's going to immediately deteriorate. But could a few days later they have that eases, they have some neck pain related to that, and they come to see us as a physio? Could there be that sort of time frame between that thunderclap headache and deterioration?
Yeah, definitely. And sometimes you can get a little mini warning bleed. And so it's really important not to ignore those, because a little bleed, like a tiny leak, can still give you a thunderclap headache, but it would possibly resolve. And then 2, 3 or 4 days later, people then get a major bleed, and that's much more life-threatening and very worrying. So yeah, always get thunderclap headache checked out.
Good, excellent. I think there's so many parallels between what you're saying with migraines and scans and as you say, just consequential findings within scans. So many tie-ins with low back pain. We see in people's spines this exact thing. And so going back to that question, do people accept psychosocial multifactorial causes, let's say multifactorial causes for their pain, more so in headaches? I don't think we can probably answer that.
I think they probably do. I think because I think there's an understanding, or generally people think, oh, migraine and stress. So I think that connection is already there. Whereas maybe people wouldn't think low back pain and stress in the same way. They think low back pain and injury. And of course, with migraine, people don't necessarily think injury. They think, oh, something's causing it. Sometimes they take it too far and think that they're causing it by behaving in the wrong way or doing things wrong. So I'd always reassure people and say, don't feel guilty about it's not your fault. You've got the genes, but it's not your fault. But I think they are prepared to look. And my experience with people with migraine is that they are constantly looking at everything they can do because it's in your head. You really want to be able to think straight, not have the brain fog, feel less fatigued, not have the dizziness. You work on everything you can to try and reduce those symptoms. I've been there. I know how people search. So I think they're very happy to look holistically at things.
Yeah, I think that possibly the low back pain PR team need to talk to the migraine PR team to see, how can we change that within the musculoskeletal setting. And so what is the best kind of advice? We're in a physio clinic and somebody's got probably, as you say, not presenting with migraine entirely, but they've got some musculoskeletal pain and a migraine alongside that. What's the best advice we as non-migraine experts can give to people, would you say?
I think the best advice, I always start with lifestyle things. I think if they can get their lifestyle regular and routine, the brain settles down, and it does. It's much more important than people realize. So I obsessionally say to people, what time do you get up in the morning? What time do you eat? What time do you go to bed? Because if I say to patients, do you eat regularly? They'll all go, yes, because they're in their usual regular pattern, which might be skipping breakfast, having lunch, which is a snack, and then not having anything till 7 in the evening. And so, by drilling down into when people eat, they suddenly, you can suddenly say, oh, well, if we drew a graph of your blood sugar throughout 24 hours, it would be really up and down. And the more you can smooth that out. So get the regularity of eating right, have the low GI foods, preferably sort of lower carbohydrate, more protein and fat, because that gives you slow release energy. Keep to a routine of sleep and have good quality sleep. So waking at the same time, beware the lie-in. So having extended sleep. Often, people think, oh, I've had such a busy week, and they'll get into bed late on a Friday after maybe a couple of glasses of wine, and they'll stay in bed till much later than they do normally, and then they'll develop a migraine attack over the next couple of days and say, oh, why do I always get one on the weekend? But if you think about the things which are changing on that Friday night and Saturday morning, that's your clues. So I think it's about being a bit of a migraine detective, looking for clues in their own behavior. Keeping a migraine diary, headache diaries can be really revelatory, actually. And there's one to download off our National Migraine Centre website. You can get apps like Migraine Buddy, and some people like those because it's on the phone. I like the migraine diaries to be really simple, partly because it's quite depressing if you're having to write down every single time you have something. Keep it simple. Just write down the maximum pain score you had that day out of 10, and what medication you took, and if you're a woman, if you were having a period or not. And actually, just by writing those down on a month, you begin to see patterns emerge. That's always after I've been doing that stressful presentation we have to do once a week at work, or with kids, it can sometimes be revelatory as well. So I had a little 5-year-old whose mum said, oh, it's every time he plays football after school. He might have been a bit older than 5, I'm trying to think now. But every time he had football training, he got migraine the next day. And so you can suddenly start to see. So I think the first advice is start to keep a migraine diary, regulate your lifestyle in terms of eating and sleeping. Obviously, de-stressing and regularly exercising is also a good part of that. And then have a chat to your GP. But if you can find a GP in your practice that has migraine themselves, they usually have a lot more information and understanding. But also, have a listen to our podcast, because all of this stuff is there in bite-sized chunks. We did it as an audio podcast because people who are light sensitive often don't want to be sitting looking at a screen watching videos. So educating yourself about what migraine is, understanding what's going on, is really important, because you can then really learn how to manage your own attacks.
Brilliant. Is there, I was going to say what's the worst advice, but I guess I'll reframe that also as
I can tell you that.
Oh, brilliant. Yes. So
I can tell you the worst
advice. Go on.
The worst advice is have some of these cocodamol.
Right.
Do not have codeine for your migraine. People often, so that is dreadful advice, and we hear it over and over. Oh, my doctor or casualty or my friend gave me these strong painkillers, cocodamol, and now I'm getting into what codeine does, or opiates. So it might be tramadol or morphine, any of the opiates. What they do is it seems as if the brain of the person with migraine is more likely to get irritated by opiates. And so although people take them, and they can be marketed for migraine, sadly, what tends to happen is they go off to sleep, the migraine kind of goes, but they're not good for the pain. They make the gastric stasis worse, so people often get worse nausea and vomiting. They're addictive if you take them frequently, but they can push the brain of a person with migraine into an irritable state where they quite quickly change from episodic to chronic migraine. And we hear them saying things like, well, I used to get episodes of migraine, but now I've got this dull background headache that's there almost all the time, never seems to go away. My normal medication for my migraine attacks doesn't work anymore. And that's medication overuse headache. And that's due to codeine, but it can also be caused if people are overusing the other painkillers that we use for acute attacks. So that might be ibuprofen, it might be the triptans. There are 7 different triptans. People often given sumatriptan don't realize there are 6 different ones. So get good advice on how to take the triptans properly. But the brain of a person with migraine seems to be, for some reason we don't really quite understand why, more likely to be irritated if those painkillers are taken too frequently. As a rule of thumb, we'd say don't take anything for your acute attacks on more than 10 days in a month. If you're having more than 5 attacks a month, I would say you should be talking to your GP about having preventative interventions. So that might be medication, or it might be injections, or it might be neuromodulation devices. And there are also various supplements that people can use. So I kind of switched back into good advice here, but the worst advice is to take opiates. The other thing, of course, is if you're taking opiates for your low back pain, you may find that your migraine worsens because of the codeine you're taking for your low back pain. So we do try and say to people, painkillers aren't the answer for persistent pain. And many people, I'm sure you agree. And there are other interventions which may be much more helpful. A whole load of things that people can do that's not just taking a stronger painkiller. They do come with a lot of problems.
And you mentioned, when you get those warning signs, you hit the emergency relief button. And I think I assumed, oh, you mean some sort of painkiller. But what kind of things would that entail?
So if you are going to treat an attack acutely, there are 3 things that the headache sort of pathways had flagged up now and guidelines. So the first thing we would advise is to take something to improve the nausea and reduce the gastric stasis, so an antiemetic. Often this has been missed out. There are ones you can buy over the counter, or there are ones prescribable by your GP. But that can be really helpful, because if you're being sick or feeling sick, or you've got gastric stasis, you can take a painkiller, but it sits in your stomach and it's not absorbed there. So it's going to be slowly to get in there, and your migraine, like a snowball gathering momentum, will have grown too big. And the later you take medication, the more likely it is that you're going to fail to get rid of that attack, or the medication's going to fail you. So an antiemetic, non-steroidal anti-inflammatories are really useful in this situation, assuming people can take them safely. So that would be things like ibuprofen, naproxen. Soluble aspirin can be really helpful. And we recommend higher doses of the ibuprofen and naproxen than normal, just to try and hit it hard. And then a triptan. So as I said before, sumatriptan, very commonly the one that people have been given. Annoyingly, sumatriptan can often make people feel very sleepy and groggy, and so they put off taking it, and so they take it later in the headache phase, And then they say, well, it didn't really work very well and it made me feel very sleepy, so I don't think I'll bother. And they haven't realized that actually there are 6 different ones they can try. So I would say go back to your GP and say, that one didn't suit me. Sometimes it does suit people very nicely. There's an episode on triptans in our podcast, which gives lots of information. It's been one of our most downloaded episodes because I think people need to know there are differences, and individuals may find that one really doesn't suit them, whereas another one is amazing and just melts their migraine away very nicely. So that's the acute. So those 3 things: antiemetic, non-steroidal or soluble aspirin, and then a triptan.
Right.
That's often a recipe for success. And if you get that right, sometimes people add in a sugary fizzy drink at that stage as well. And there is not something I recommend as a health food, but Coca-Cola has fizz, which dissolves the medication to a large surface area, has sugar, which quickly corrects the brain from feeling hungry, if that's been a contributory factor, and it has a bit of caffeine. So caffeine can help painkillers to work as long as people are sensitive to it. So if people haven't been having lots of caffeine, then caffeine in that combination can be quite helpful. And it's often added to medication. So if you look on the shelves in pharmacies, you'll see paracetamol plus caffeine or aspirin plus caffeine. Paracetamol is a bit weak for migraine pain. Some people use it. It's better if you use it with an antiemetic. Metoclopramide is sometimes used. Somebody did a study that showed that if you take paracetamol with metoclopramide, it's 10 times more effective for migraine pain than paracetamol on its own.
Fair enough. Oh, brilliant.
Yeah.
And are there any other myths that you would like to bust? As you say, don't take opioids for pain relief, and people being safe actually to use HRT with migraines. Are there any other common ones that you hear?
Yes. So there's a thing that people say, which is, I just get the normal headaches. And I normally say to them, that isn't a normal thing. It isn't normal to get headaches. Headache is a symptom. It's not a diagnosis. So it'd be like saying, I just get the normal cough. No, why are you getting the cough? There's a reason behind that. So I like to pick people up on that. And the other one is people talk about cluster migraine and they say, I've got cluster migraine. And we really discourage that because there is a really important primary headache condition called cluster headache, which is quite different from migraine. So what they mean is I'm getting a lot of migraine coming frequently, which is defined as chronic migraine, or we would say you're having bouts of migraine or high frequency migraine rather than use the term cluster. So cluster is a one-sided severe headache with rapid onset of pain, lasting anything from a few minutes up to 3 hours, sometimes in repeated attacks in a single day. And it gives watering of the eye, red, watery eye on the same side, stuffy nose, and it's excruciatingly severe. But the main difference in the story is that people want to walk about. They really get agitated with cluster headache. They have to bang their heads. Sometimes they punch themselves or bang the wall because the pain is so intense. And so we really need to raise awareness of that much rarer condition because if they get treated with oxygen or sumatriptan injections, they can have a much quicker relief of those horrible attacks, sometimes called suicide headache, because people get so desperate with it. Any other myths I can think of? Well, the myth is sometimes people get confused because they know that they shouldn't overuse medication, so they delay taking it, and so then that makes the medication less effective. But what they also don't realize is that if you take it more on day one, So you take one dose at the beginning and maybe another dose later and squash the migraine attack so that it's not rolling on to day 2 or day 3. You're actually going to get more benefit and quieten the brain down. So getting in there early in treatment is really important. And the problem comes sometimes when GPs have said, oh no, you can only have 6 tablets. And actually with sumatriptan, the maximum dose that you could take in a day is 6 tablets if they're 50 milligram tablets. So it's really about understanding what the dosage regime is and getting really clear plan for that.
No, excellent. And sort of brilliant roundup there. I think if we're in a clinic with someone, and particularly now where it's very difficult to refer to a GP, it's very difficult for people to see their GPs.
Yeah.
When is it that you're thinking, we want this person to be referred on, and where can we send them if not their GP? Certainly their GP would be a good idea, I imagine.
Yeah, I think GP, I mean, it depends really on how frequent the attacks are and how much they're impairing their activities of daily living. So I think if somebody's getting mentions that they're getting occasional attacks, maybe once or twice every couple of months, they can work out a good regime by listening to our podcast and maybe chatting to pharmacists. If the pharmacists hopefully have got good information, and they can sort those out themselves. When it's getting a bit more frequent, or what they're doing, the basic things have been covered and they're thinking, oh, it's really not quite working for me, then they need to see a GP to get prescriptions for various things like the other triptan. Sumatriptan you can buy over the counter, but the other ones you do have to get a prescription for. If attacks are becoming more frequent or those acute treatments are not working, then I would say they need to see a GP and talk about preventative interventions, as I mentioned, medication injections or neuromodulation devices. And GPs are normally more familiar with medications and can prescribe a range of those. Injections and neuromodulation devices tend to be coming after people have tried several of the medications and they haven't found the solution for their migraine attacks there. And that's when they then need to be referred on to a more specialist service. And I always encourage people to ask to be referred to a headache specialist, because with the best will in the world, general neurologists are often have more expertise on Parkinson's or epilepsy or in multiple sclerosis, where sometimes to get really good advice from headache specialist services is just much more useful for patients. And sadly there are long waiting lists. And one of the things I hadn't mentioned is supplements. So going right back to square one, if people are just thinking, what can I do myself? There are 3 evidence-based supplements that we recommend: magnesium, vitamin B2, and coenzyme Q10. I also am more frequently recommending people to take vitamin D because there's some evidence that prevents acute migraine from going on to becoming chronic if people make sure their vitamin D levels up there. So so find out what you can do. Our website has fact sheets on these. The Migraine Trust website has brilliant fact sheets. And I have written a book called Managing Your Migraine, which is coming out in August, which summarizes all these kind of things. It's basically aimed at enabling people to work out the first stages of what they can do to help themselves. So I think, going back to your question, when to refer on, if they're doing all the things they know that they can do themselves and they need medication prescribed, but if they then are struggling with the medication because of side effects or lack of efficacy, then they might need to move on to a specialist. And I think the other thing we come across quite commonly is people saying, well, my GP prescribed something, for example, like amitriptyline, 10 milligrams, and I took it for a fortnight and it didn't work. So we'd always say with any preventative medication, you need to get to the maximum tolerated dose and stay on it for at least 3 months before you can judge whether it's going to help you. And obviously the maximum tolerated dose means you have to balance the side effects with the benefits. But sometimes side effects are there for the first couple of weeks and then settle down. So don't abandon things too quickly, I think, is the message. Just to keep going, be patient. Sadly, you do need to be a bit patient with these things.
Yeah, so tricky when you're in the middle of a migraine attack, I imagine. But no,
oh yeah,
advice. But brilliant, thanks so much, Katy. That's such a jam-packed episode of stuff that we as physios don't know loads about. So I think it's important to say, as you mentioned, the National Migraine Centre has a lot of information. I had a look on it before this session, lots of downloadable information and fact sheets. What's their website address? Do you know off the top of your head?
I do. It's www.nationalmigrainecentre.org.uk.
Excellent. And of course, as part of that, you have the podcast, the Heads Up podcast.
Yes, that's on the website, but it's also on Apple and Spotify and all the usual podcast places. And if people do find it useful, please write us a review on Apple, because the more people that write reviews, then the more Apple podcast curators will notice us, and then they start to promote it, which, what we're all about basically is getting the message out there to as many people with migraine. 1 in 7 people getting migraine. There's an awful lot of us that get it. So the more we can educate, the better, really. Yeah.
Go and download Heads Up, podcast fans, and which we know you are. And as you mentioned, your book, which comes out in August, that was Managing Your Migraine. Is that right?
It is, yes. It was. It's commissioned by Penguin as part of their Penguin Life Experts series, which is launching with my book, and also a book by Dr. Louise Newson on preparing for the perimenopause and menopause. So we'll be doing some stuff around that time. Hopefully we're going to do an episode of the podcast about migraine and menopause, so listen out for that one. But yeah, very excited to have been able to do that. And I've tried to make it as comprehensive as possible to give people the tools, really, because what I found is, in my personal journey with migraine, is that I needed to educate myself, find out about my particular migraine attack and what I react to and what I can do to help myself. And I think it is very individual in that way. And there's no one rule that we can say, well, if everybody does that, then everybody will be fine. So look after yourselves, I guess, is the message. But trying to get good information is the very good start.
Brilliant. No, hugely important work. So yeah, we look forward to that coming out in August. That's brilliant, Katy. If people have any questions for you, can they reach you on social media?
Yeah, I'm on Twitter, Katy Munro 1, or I'm on Instagram as @migrainedoc.
Brilliant. Thank you very much, Katy. Thank you once again. And thank you all for listening.
Thanks for the invitation.
So a little bit different, that one, I feel. Certainly something I didn't know a lot about before, and yet so many parallels between things like migraine, complex head pain, and persistent low back pain, persistent widespread pain. So certainly lots to be learned from Katy, and thanks so much for her time. And do check out her book coming in September. From a Physio Matters point of view, do check out Chewing It Over every day at 12:30. That's Jack Chew. Chewing it over, as it says on the tin, various topics on a day-to-day basis. Do follow us on social media at TPM Podcast and send us an email if you did enjoy this session, if you've got any questions. And do check out also our other podcasts, Massage Matters and You Matter, covering a wide spectrum now. And I will direct you again to physio-matters.com. Check out the recordings from Therapy Live. You can purchase them all there if you're not already a member. And so thanks very much for joining me, Felicity Thow, and Dr. Katy Munro, who has recorded our sign out.
You've been listening to the Physio Matters podcast, discussing physio matters, because physio matters.